Good afternoon to everyone. From Gynae Unit 2, we are going to present a very challenging case. And I present before you Dr. Anshul. She is fellow in Minimal Invasive Surgery Division. She will present the case. Dr. Abir is our senior resident. He will discuss the case. Dr. Binita is here. Without anesthetist, this case would not have been possible. Dr. Binita, associate professor from Department of Anesthesiology, will give her inputs in this case. Thank you.
Thank you, sir. Good afternoon, everyone. So today I'm going to present a case, a recently operated case from our unit, a fascinating and challenging case on telescopic navigation through a stormy sea. A 40-year-old para 3 living 3 resident of Basant New Delhi attended gynae OPD with a 3 months history of pain in lower abdomen, which was continuous, dull aching, and it was non-radiating. It was associated with gradually progressive abdominal distension and heaviness in lower abdomen. Coming to her menstrual history, patient had attained surgical menopause since year 2014. Her previous cycles were irregular and she had heavy flow. She was diagnosed with fibroid uterus, for which she underwent total abdominal hysterectomy in year 2014 done in private hospital, New Delhi. She is married since 20 years. She is a para 3 living 3. All previous full-term LSCS. Her last cesarean section was done in year 2006. Coming to her personal history, she is a non-smoker, non-alcoholic, and she has normal sleep and bowel habits. There are no previous history of any chronic medical illness. Now coming to her surgical history. So our patient has a previous history of 6 abdominal surgeries in past. Let's see them in details. First of all, she underwent her first cesarean section in year 2001. Her second LSCS was done in year 2003. Her third cesarean section was done for her in year 2006. Following this, she underwent total abdominal hysterectomy in year 2014. In year 2016, she underwent laparoscopic cholecystectomy. And lastly, she underwent a laparotomy followed by left salpingo-oophorectomy in year 2019. On general physical examination, patient was conscious. She was well oriented to time, place and person. Her BMI was 26.1 kg per meter square and her general physical examination was found to be normal. On per abdominal examination, upon inspection, her lower abdomen was uniformly distended. Multiple old healed laparotomy, laparoscopic port site and cesarean scars were visible. On palpation, an ill-defined abdominopelvic mass of approximately 16 weeks gestation size was palpable, more towards the right. It was cystic in consistency and its margins could not be felt. Its side-to-side mobility was restricted and it was tender on deep palpation. Its lower limit was not reached. On percussion, dullness was present all over the mass. On local examination, the external genitalia appeared normal. And on per speculum examination, the vault appeared healthy. On per vaginal examination, a vague cystic fullness of approximately 10 by 8 centimeters was felt towards the right. Its side-to-side mobility was restricted and it was tender. No abnormality was felt on the other side. On per rectal examination, the same mass was felt and the rectal mucosa felt free. We got her investigated and her complete blood counts and blood chemistry were found to be within normal limits. We got her tumor markers done which showed to be within normal limits. Her chest x-ray showed normal study. Her transabdominal ultrasound revealed a 12 by 8 centimeters sized multicystic lesion which was arising from the right adnexa, but its exact origin was not clear on ultrasound, though it showed no vascularity within. She had also brought a siege CT scan done from outside along with her, which showed a well-defined thick-walled cystic lesion seen arising from the pelvis of approximately 13 by 9 centimeters size. It showed few internal septations within. This mass was seen adhere to these bowel loops and it was displacing these bowel loops laterally. So with this presentation, this patient visited multiple practitioners outside. And as we all can really understand, none of them were ready to operate upon her or to even touch her. Finally, she landed up in our gynae OPD and we too faced the same dilemmas and the difficulties. The dilemmas in terms of how should we approach this patient, how should we proceed with her, should we opt for a laparotomy or should we go for a laparoscopic approach in her case, both of which would be equally challenging. And the difficulties we anticipated were in terms of the anticipated in terms of dense bowel adhesions and the risk of bowel and bladder injury in her case. But with the past experiences we had, we finally decided to proceed laparoscopically for this patient. And finally, on 4th of February 2022, we performed a laparoscopic adhesiolysis followed by right oophorectomy was done for her under general anesthesia. So, after deflating the stomach using Rice tube, the biggest challenge in front of us was where to make the primary port placement. So, as we all can see here in this video, these are the ports, laparoscopic port scars, which was chosen for her for the laparoscopic cystectomy done for her in the past. And this is the midline vertical laparotomy scar, and this is its supraumbilical extension reaching till this place. So, between these two scar sites, upon assessing the relative mobility of the anterior abdominal wall in respect to the intra-abdominal structures, this area we found was relatively mobile. And at this area, we anticipated least bowel adhesions. So we chose this area for our primary port placement. We made an incision and using a 5 mm trocar and cannula and using a direct entry approach, using a 5 mm telescope, we entered inside, and as we all expected, we could see a nest of adhesions covering the entire abdominal cavity. And as we all can see here, the bowel and the omentum was seen nicely hanging with the anterior abdominal wall. By God's grace, we could find some adhesion-free space towards the left, which we chose for our first lateral port, and subsequently the third port was placed under vision. We were very cautious not to injure the bowel while port placement. We started performing adhesiolysis. Here, as we all know, that the limitation with the 5 mm telescope is the narrow field of vision, and sometimes clarity is also a bit of problem. So we started clearing the adhesions which were near to our primary 5 mm primary port which we had placed, so that we can convert this 5 mm primary port into a 10 mm port. And we did this under vision through our 5 mm telescope. Now upon entering inside using a 10 mm scope, we started searching for our target, which was actually nowhere seen. It actually appeared like a search in a maze of additions, but we kept our hopes alive and we trusted that there is always light at the end of a dark tunnel. Routinely, we perform laparoscopic cystectomy and laparoscopic oophorectomy as a 3-port surgery. But in this case, as we all can see here, bowel was so densely adhered and it was not obliging us at any point. So we had to put in the fourth port. So now being in a better condition, we continued performing adhesiolysis. We cautiously separated the bowel and we continued searching for our target area. And very soon, as we all can see here, we found a very small window of approximately 1 to 1.5 centimeters, and through which we could see the cyst peeping off, and it was densely adhered under the bowel adhesions. To get some space, as we already knew with the tumor marker reports and with the imaging, it to be a benign, we just gave a superficial nick over the cyst and we could see the clear fluid draining out. Upon inspecting it from inside, we saw a clear fluid containing cyst with congested walls all around. It actually appeared to us like a pond. After suctioning out the contents, we started separating the bowel away from the cyst wall, and we used harmonic for this purpose. As we all know that, as in this case, when the bowel or the vital structures are in such close proximity, the harmonic is the safest as the thermal spread is least with it. Also here, we took utmost care not to touch the bowel loops with this harmonic scalpel, as it tends to be really hot and it might injure the bowel. So now, as we all can see here, we were finally able to reach the base of the ovary, and we were finally able to successfully perform the right oophorectomy for this patient. We took out the specimen through the port, and at the end, we finally performed a thorough irrigation and suctioning of the operated area, and we came out. So this is the final post-operative picture of the patient's abdomen. Post-operatively, the patient was discharged after 48 hours. Her post-operative course remained uneventful. This is the pre-operative and the final post-operative picture of the patient's abdomen. And we discharged on post-operative day 3, and she left for her home with a twinkle in her eyes and a gorgeous smile. So we followed her histopathology report also, which revealed a benign ovarian cyst with chronic inflammation. Now I would like to invite Dr. Aveer, our senior resident, for the discussion part. Thank you all.
Thank you, Dr. Anshul. This case was indeed a nightmare for laparoscopic surgical access. Now, let us come to the discussion part. Today, we are going to discuss how to decide for laparoscopy versus laparotomy in such conditions where we have a densely scarred abdomen. What are the techniques of port entries? Role of miniature endoscopy in today's day laparoscopy, and how to approach the target with so much of adhesions. Laparoscopy is possible even in the most challenging situations. It all depends on the skill of the surgeon, good assistance, and availability of a dedicated multidisciplinary team approach. The most challenging situation in a scarred abdomen is how to go about the port entry. This is because there is risk of inadvertent injury to the bladder and the bowel. Therefore, knowledge and practice of using a variety of entry sites and techniques can reduce this risk to a minimum. Let us see what are the various port entry techniques which we can try in a scarred abdomen. First of all, we can enter through the Palmer's point, which we'll discuss further. Then we can enter through the Hassan's technique, which is an open entry trocar entry. We can enter through the 9th and 10th intercostal space, and nowadays we have optical trocars available with us. Palmer's point is a point in the left upper quadrant of abdomen. After deflation of the stomach, the exact point of introduction is located in the mid-clavicular line, 4 to 5 centimeters below the left costal margin. Now, this point is usually chosen because it has nearly zero risk of injury to large vessels. This video is done, this case was done in our department, where this patient had a dense scar, a midline laparotomy scar, and we anticipated dense periumbilical adhesions in this patient. So we marked the Palmer's point, which is actually 4 to 5 centimeters below the costal margin, and Veris needle was inserted into the Palmer's point. After creating a pneumoperitoneum, we entered through a 5 mm trocar, and 5 mm telescope was used. On entering the abdomen, we could find dense intra-abdominal adhesions inside. So we used harmonic scalpel to do the adhesiolysis as much as possible so that we get space for 10 mm trocar entry. After entering the 10 mm telescope, we proceeded further with the oophorectomy and the rest of the procedure. So this Palmer's point of entry is tried in very extremely obese patients, in patients who are very thin, where great vessels lie 1 to 2 centimeter underneath the umbilicus, in case of large pelvic masses, where we perform laparoscopy in second trimester with gravid uterus, and in cases where there is failed umbilical cannulation. The contraindications of this technique being previous splenic or gastric surgery, significant hepatosplenomegaly, portal hypertension, and gastropancreatic masses. Coming to Hassan's technique. In this technique, incision is made at the base of the umbilicus, abdominal layers are retracted, and then peritoneal entry is done under vision. But there can be chances of gas leakage in this technique, so peritoneal incision is made as small as possible. Stay sutures are tied in the linea alba or rectus sheath, and we can use a specific Hassan's entry trocar and cannula with flanges. Coming to the entry through 9th and 10th intercostal space, the indications and contraindications are similar to that of Palmer's point. This point, we access the anterior axillary line along the superior surface of the lower rib to avoid injury to the underlying neurovascular bundle. There is another point called Li Huang point, which is located at the midpoint between the xiphisternum and the umbilicus. It is accessed in case of large pelvic masses like huge fibroids and where there is failed umbilical and Palmer's point entry. Nowadays, we have improvised techniques whereby we use Hassan's technique of open entry beyond the lateral border of the rectus muscle in case of very dense midline laparotomy scars. Coming to the most recent techniques whereby we use optical trocars. In these trocars, abdominal layers can be entered under laparoscopic vision. So as we enter the abdominal layers, we can visualize them properly, thereby preventing injury to any vascular structure or any vital organs. These optical trocars have been modified further in the form of VisiPort, where sharp cutting blades of 1 millimeter of length is advanced each time, which enables the tissue to be transected. These blades retract swiftly into the trocar after the trigger action is over, thereby preventing injury to vital organs. There are other techniques of periumbilical ultrasound guided saline infusion, whereby we inject small amount of sterile saline into the area of laparoscopic entry. If there is loculation or lack of dispersion of this injected fluid, then it signifies dense subumbilical adhesion. This technique has a sensitivity close to 100%. Coming to role of mini laparoscopes. Mini laparoscopes have come as a boon in modern era of endoscopy. In a densely scarred abdomen, these mini laparoscopes are useful in viewing the Pandora box, whereby there is easy access to the scarred abdomen, improved cosmesis, for faster recovery, and we can use nowadays in various surgeries in gynecology like cystectomy, salpingo-oophorectomy, detorsion, and even in hysterectomies. This Cochrane review has compared various entry techniques, that is open technique, closed technique, direct technique, and various needle technique. We have found that direct technique and open technique are useful in preventing omental injury, whereas direct technique can be favored in case where there is failed previous entry and for extraperitoneal insufflation. Now, coming to choice of the energy source. Harmonic has also come as a boon in modern day endoscopy. It uses ultrasound technology to cut and coagulate tissues at very lower temperatures, that is 3 to 4 times lower than electrocautery and lasers. So with lesser degree of lateral spread of thermal damage, there is decreased risk of injury to the surrounding organs. And as we have seen in our index case also, the preferred energy source for adhesiolysis near vital organs is harmonic after all. But how to approach the target organ in cases where we are unable to introduce the harmonic also? In that case, we can approach through extraperitoneal space entry also. This study published in 2021 from our department has shown that extraperitoneal laparoscopy is a safe alternative to laparoscopy in dense intra-abdominal adhesions. Let us see. In this case, when we entered through the 5 mm trocar and telescope, we found that there was very dense adhesions in the extraperitoneal cavity also. We could not visualize anything. We could not even visualize the peritoneum also. So what we did is we tried to insufflate into the extraperitoneal space itself and tried to dissect the adhesions as much as possible, trying to remain in the extraperitoneal space only. Now, under vision, we tried to get access for another 5 port. So we find here that under vision of the main port, we entered the harmonic scalpel through the 5 trocar, and we tried to do adhesiolysis as much as possible, trying to remain in the extraperitoneal space only. When we approached the target, that is the ovarian cyst, we tried to put a nick, a small nick into the peritoneum, so that now we can approach the intraperitoneal cavity. On putting the small incision in the peritoneum, we could find that the cystic fluid was draining. So we introduced the harmonic and tried to extend this incision, and we entered the intraperitoneal space, thereby reaching our target organ, and proceeded with oophorectomy further. Just a short glimpse on the available review of literature. Due to paucity of literature, only a handful number of published studies could be found where laparoscopy was possible in dense scarred abdomen. We have done a plethora of such challenging endoscopic surgeries in our department, among which this very case had the maximum number of previous laparotomy scars. It has indeed shown that laparoscopic surgery is possible even in the most challenging situations. Thank you. Now I request Dr. Vinita from Department of Anesthesiology to share her experiences in this case.
Well, firstly, congratulations to the entire surgical team for such a wonderful case. It was fascinating to watch, even though I don't understand the 5 port and the 10 ports in such detail, but it was fascinating to watch. And for the first time, probably I watched the surgery more on the screen now than I would have probably during the case while it was going on. So firstly, congratulations to the entire surgical team. The anesthetic challenges in this particular patient were basically primarily three. The first was because of the dense adhesions, and whenever patient has undergone several surgeries prior, so there is often some nerve transactions and some anatomical distortion which always takes place with every subsequent surgery, and therefore the chance of postoperative pain is usually significantly higher, along with intraoperative pain as well, because we don't know what nerves have been transected in the previous surgeries. So the management of the postoperative pain becomes super important in such cases. So we tackled that by giving intrathecal morphine along with a small dose of bupivacaine preoperatively, which helps to take care of the pain not just intraoperatively but also for a good 16 to 24 hours postoperatively. Fortunately, this was a laparoscopic surgery and this was completed successfully laparoscopically. So the amount of pain that the patient might have experienced has been brought down significantly. Our backup plan was that should the patient be opened up, or by any chance if a laparotomy was to be planned, then we would have supplemented this with a postoperative epidural catheter insertion, which would have taken care of pain for the first 48 to 72 hours, thereby prolonging the amount of analgesia and providing a better quality of postoperative stay for the patient. So that was about the intraoperative and postoperative pain. The second is that in such cases of adhesions, as the surgical team has correctly pointed out, that you don't really know what you're going to face till you go inside. So there is a possibility always of prolongation of surgery and of a possibility of slightly increased blood loss as compared to a normal surgery. So fortunately, this was tackled by taking an additional IV cannula prior to surgery, and we checked that blood is available. So this was fortunately we never came to that because there was a total intraoperative blood loss only of about 150 ml, which is fairly minimal, and the duration of surgery was also hardly more than 1 hour 45 minutes, which was very well tackleable. So these two were also could have been possible challenges, but fortunately we never needed to tackle those challenges because we never came down to that. We were lucky also in the fact that the female was young patient. She was not obese. She did not have any major systemic comorbidities that would have complicated our management otherwise, except that she had some ECG changes in the form of T wave inversions. Fortunately, again, she was otherwise very well preserved. Her cardiac status was good. She was able to take up the entire surgery without much of hemodynamic fluctuations, except at the point which usually happens at the point where the large cyst is deflated, and then we have a sudden hypotension. Again, that could be well managed with a bolus of intravenous fluids. She never needed to go on any vasopressors or anything else because otherwise she was young and very well preserved with no other comorbidities. So altogether, there were a few possible challenges which could have taken place, and we had our plan in place. With God's grace, as someone has said, that things went fairly smoothly, and we never really needed to resort to our plan B at any given point of time. So that is about the anesthetic challenges, and congratulations again to the surgical team for a wonderful presentation. Thank you, sir.
You see, that was indeed very challenging. And I must tell you that I got all inspiration and encouragement from the team. Everybody said, we don't know what is going to happen because everywhere there's a scar. I must thank everybody in the team and in the unit for doing this case. And you know, the anesthetist is the most had a very vital role. They were also wondering, don't know what is going to happen because looking at the scar and all. And I must thank Dr. Benita because you know we know that whatever happens, it will she will manage. Only my worry was gut and bladder, nothing else. And I know that if I am in, I'll be able to manage. Thank you very much. I would like it's open for discussions. Before that, our laparoscopic surgeon, Dr. Professor Sinu, is here. If you would like to give some comment and your experience. Thank you for coming.
Thank you, Kalul. First of all, hearty congratulations to you and your entire team for taking up such a difficult case and managing it so successfully. See, Kalul has been doing laparoscopic surgery for more than 3 decades almost now. So experience does make a difference. I want to make just few comments about the case which has been really well presented and the literature which has been very well reviewed. See, whenever you present a case, no, you have to do at the end of your physical examination a diagnosis and differential diagnosis. These two things are extremely important before you, because in institute what happens is patient comes with all the investigations, you know the diagnosis, a patient tells you the diagnosis, but that doesn't happen in real life situations. So present it as if you're standing in the OPD or sitting in the OPD, you have taken the history, you have done the exam, and then what's your diagnosis, and then the differential diagnosis. That is one thing. And second thing is, see, this patient had just pain in the abdomen. Okay, her pain could have been because of all the surgeries she has undergone. So in your follow-up, you have to always tell us what has happened to her pain. Like, we have to first of all not only treat the cyst, we have to treat the patient's symptoms, whether her symptoms became better, whether the patient did well following surgery. So that tells us whether what we have done is really successful. And coming to the technique, and again, I once again say that it is very well performed surgery. But the very fact that there is more than one way of creating pneumoperitoneum suggests that none of the techniques is the best. So first rule is that follow the technique which you have been doing all along. Okay, so usually your results will be highly successful. And always pre-plan. Whenever you have such a difficult surgery, I'm very sure Alol would have been thinking about it when he's walking, even in his sleep, he might have been thinking about it. Okay, so plan it properly and do it diligently. And next thing is, once you go in, again, harmonic scalpel, don't think harmonic is temperature is just lower as compared to electrocautery. But you touch the tip of the harmonic scalpel, it usually causes a very deep burn. So if there are adhesions, especially around the bowel, always use a cold knife, use a scissors. Okay, after that, if there is a bleeding, you can use a bipolar or something to control it. And then this another very interesting technique is the extraperitoneal approach. This we have been doing it for the hernias, laparoscopic sorry, inguinal hernias now, even for the ventral hernias, we use it. So there will always be adhesions there. You have to release them, and then from there entering it at the right point where, as Kalol has done, I think that's a very real good way of tackling the patients. All in all, I think a fantastically managed case. Thank you.
Thank you very much. Anybody has any question? Yes, sir. Sir.
In question, what is the outcome for operation, and in the other case, in country or in as per, or is there any role in robotic surgery now in next result?
It is a very good question. Professor Biswas is my dada. In Calcutta we tell dada. He is a director in that IGM in Patna. Now he has come back, and it was a very good question. You see, uh, uh, whenever this scarred abdomen, and along with there is some pathology, some target which is we have to approach. And I tell you that previous 2 surgeries, 3 surgeries, nowadays 4 surgeries. Yesterday we presented one. She had a pancreatectomy, she had a splenectomy, she had a hysterectomy, she had a ovariotomy, all, and after that we did. So the results are really good, because as Professor Sinu has already mentioned, that we should have mentioned that her pain has gone, and in fact the diagnosis was written on the basis of ultrasound, though there is on the PV examination there is a mass, and because there are additions, you can't really delineate that what is the mass on PV examination, per vaginal examinations. But ultimately, we knew that it is ovarian cyst, and then we have to reach the target. So, answering your question is that the results are very good, as Dr. Binita also said. And I am so thankful to the anesthetists that they anticipate and they put always intrathecal morphine or some regional, all this. And you believe us that there was no pain, and the patient was feeling hungry next day. Patient feels hungry means everything is all right. And on third day we could discharge. Very interestingly, I get this lesson from the surgeons, because I always peep from they know that I go to OT4, OT5, and I peep from behind and I see what is happening. And I saw their surgery, that hernia repair, that how they can do it extraperitoneally. And I got this concept from here only, that extraperitoneal can be done in a situation where I cannot go interperitoneal and reach the target. So I always thank that. And the beginning started from our senior residents. We had an exchange program in Vallabhgarh, that you do hysterectomy, I do cholecystectomy. Of course, that time the laparoscopy was not there. That time, open surgery was there. So thank you very much, Professor Sinu, for the, and I think for the students it is very good. They should have a provisional diagnosis and differential diagnosis, and the students, they have to present like that. Thank you very much. Anything else? Anybody wants to ask any question? Yeah, robotic. Yeah.
Because the first step basically to create pneumoperitoneum, which is same for both.
See, once you are very good in laparoscopic surgery, well, a robot has got some added advantage if you are near to some target which is a vital organs are there. A precise cut can be with a robot. But docking, de-docking, this takes a lot of time. And not only the time, now robotic surgery once upon a time became very popular. I said once upon a time. Now the popularity is declining. because the surgical skill, if you are a good laparoscopic surgeon, if you have that's particularly the suturing technique and all, robot has a big advantage in suturing. You need not to be a laparoscopic surgeon for a robotic surgeon. Robotic surgery can be started by a senior resident without any laparoscopic experience. So, well, a robotic has got some advantages, but as Professor Sinu said, that in any case, you have to go in, and going in a scarred abdomen is not, it's always challenging. Thank you very much. Anybody has any question? Yes, please, sir. Thank you so much. Thank you. Yeah, this I must thank my team because I only do the surgery, they do the rest of the thing. And the assistance is very, very vital. Your assistant is not all right. I always tell that 60% job is done by the assistant, 40% is by the surgeon. The skill is involved there. Thank you very much. Maybe the COVID, because of the COVID, we don't know, but it may be the excuse.